Okay. Yeah. Good afternoon. We will starting the pediatric session. First of all, I would like to all attendees who's coming physically to attend physically and those who attend with us on Zoom. Actually, we have more than 110 on Zoom. So even the physical attendees are less, but already there is more than 120 now are attending the pediatric session on live on Zoom with us. And I would like to call Dr. Suhail, the chairman of Pediatric Congress, to starting the pediatric session. Dr. Suhail? Dr. Suhail, your talk.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon. My name is Suhail Shabib. I'm the pediatric gastroenterologist that organized this pediatric part of this symposium, the Congress. I welcome you all to the second Maternal and Health Congress. We have good attendance on Zoom. The whole Congress, I'm glad to say that we have close to 500 attendees between physical and Zoom audiences. This Congress is sponsored by the Hospital for Women and Children, the Royal Hospital for Women and Children, and it is in support of the National Health Regularity Authority, which abbreviation NAHRA, the licensing body in Bahrain. As the chairman of the pediatric part of this symposium, I have ensured to organize the pediatric part will provide wide variety of subjects to cover both the infant and child care in health and disease. I would like to thank everybody who contributed to this Congress and work to have this Congress a true success. Special thanks for our eminent speakers. We have several international speakers as well as local Bahraini speakers, which really makes this conference truly an international conference. We will start session 1 now, and each speaker will take 30 minutes, 25 minutes of lecturing, and we will preserve 5 minutes at the end of each lecture's time for questions and answers. Dr. Muhammad, would you like to present introduce our first speaker? Thank you.
Good afternoon. We will start our conference today, the first session, by an eminent speaker, Dr. Jamaluddin Al-Kouchi. He is a very distinguished intervention radiologist and the chairman of the clinical imaging in Abu Dhabi Saha at Tawam and Al Ain Hospital. He is associated professor in radiology in United Arab Emirates Universities, one of the founder of the interventional radiology in Arab Emirates, and he is the longest served in the international radiologist in Saha, and so he has a very long experience in the intervention radiology in Emirates, and we will gain a lot of experience from his side. He is the first DOH licensed intervention radiology in Abu Dhabi. Dr. Jamal started working in Saha as the chief of the intervention radiology at Sheikh Khalifa Medical City between 2007 to 2010. And he is still giving a lot of his experience in Abu Dhabi and all over Emirates. And I think it is the time now to gain some of his experience in Bahrain. Dr. Jamal, the floor is for you.
It's my great pleasure to be with you, and I would like to thank the organization committee to invite me to speak at this conference. And I'll be talking over the next 20 minutes about the role of TIPS in kids. TIPS stands for Transjugular Intrahepatic Portosystemic Shunt. My name is Dr. Jamal Kouchi. I'm the chair of clinical imaging at Tawam Hospital, and also chief of the intervention radiology. And also, I'm adjunct associate professor at the university. Just a brief history about my employment over the last 15 years. I have been working in the Emirates of Abu Dhabi for the last 15 years. Started at SKMC, Sheikh Khalifa Medical City in Abu Dhabi, and then I moved to Al Ain, where I have been working between Tawam and Al Ain Hospital. I've done around 50,000 IR procedures over the last 15 years, and I've done many procedures related to children. And I had the pleasure to work over the last 15 years under the flagship of Cleveland Clinic, Johns Hopkins, and Saha Vamid. We all know the intervention radiology has changed the way we practice medicine, and many big procedures and surgeries in the past, they have been replaced by a minimally invasive intervention radiology procedure. As these IR procedures, they are really very, very invasive, and they can be done through a small hole in the groin or in the hand or the neck, where we can reach the area of disease to make the diagnosis or to deliver a treatment. This is just a picture of our future hospital in Al Ain City. And I had the pleasure to work with Dr. Suhail Shbib previously in Abu Dhabi, and we've done many exciting work together. And I'll share with you some of them. So what TIPS stands for? So TIPS is Transjugular Intrahepatic Portosystemic Shunt. It's an intervention radiology procedure by which we insert a catheter from the neck, and then under X-ray and ultrasound guidance, we guide a big needle and catheter from the jugular into the SVC and down to the right atrium, and then into the hepatic veins in the liver. And then under X-ray and ultrasound guidance, we do a puncture inside the liver to connect the portal vein and the hepatic veins. And the main indication for this procedure is to decompress the portovenous system in order to stop varices bleeding or symptoms of portal hypertension. Again, this is another picture which shows exactly where the TIPS fits in. So it's a connect between the hepatic veins and the portal vein, and is done under IR guidance. What are the indications? So we have around 6 indications for TIPS. Most common one is uncontrollable varices bleeding in the stomach or in the esophagus, and also recurrent varices bleeding despite of endoscopic treatment. And also we use it for portal hypertensive gastropathy and refractory ascites, in addition to the hepatic hydrothorax and Purd-Chiari syndrome. So this picture, I show you the steps. So we start by the right jugular vein puncture, and then under X-ray guidance, we go to the SVC, right atrium, and then hepatic vein. And then from the hepatic vein, we puncture into the portal vein, and then we dilate the tract once we hit the portal vein, and then we insert the stent graft, and then we do a contrast injection to check the patency and also to look for any varices which we might need to embolize during the procedure. This is the needle which we use. It's called the Cheetah Needle. It's a very clever needle. It has angulation and also some marker for direction to tell you where to puncture, anterior or posterior. It depends on which hepatic vein you are in. And as I said, it's done under ultrasound and X-ray guidance in a sterile manner. And this is the stent which we use to connect the hepatic vein and the portal vein. And once we are inside, so we release the stent, and then again, we do a contrast injection to check for any gastric or esophageal varices still appearing after inserting the TIPS stent, so we could embolize it during the same procedure. Of course, patient preparation is very important, especially the lab test, the coagulation profile, also renal failure function, INR, BT, BTT. In addition to that, also we need neurological examinations, especially the status of the hepatic encephalopathy, if there is any. And also we need a CT scan and Doppler for the liver to check on the patency of the jugular vein, hepatic veins, portal vein. And also if there's any paracentesis, we have to drain it before the procedure. And of course, the procedure in children is done under GA, as difficult as it's to do it under sedation only. And very important, after TIPS, patient has to be hospitalized in an ICU bed, as there's a high risk of hepatic encephalopathy immediately after the procedure, especially also the hemodynamic changes after putting the shunt inside. Contraindication, there aren't many really, but patient with right and left heart failure, they are at risk of deteriorating if we do a TIPS for them, and also patient in child abuse C, the liver function might deteriorate, plus hepatic encephalopathy. If the patient already in hepatic encephalopathy, if you do the TIPS, their condition will get worse. And of course, like untreatable biliary obstruction, and also polycystic liver disease. And of course, also if there's in the liver large hepatic tumors or metastasis, it's a contraindication for this. And very important also, when there is coagulopathy, which cannot be corrected, so the procedure will be contraindicated, as there will be a high risk of bleed. Again, bilirubin more than 5 mg, also is one of the contraindication for TIPS. These are some of the conditions which are contraindication for TIPS. As you can see, some ultrasound and CTs for polycystic liver disease, and also liver tumor, and also obstructive biliary system. Again, this is a picture which shows the hepatic veins anatomy. So we usually have 3 hepatic veins, left, middle, and right, and usually we choose the right hepatic vein to puncture from that vein anteriorly to hit the portal vein. If we catheterize the middle hepatic vein, we have to puncture posteriorly. This is all due to the spatial anatomy inside the liver and the relationship between the hepatic veins and the portal veins. This is the first case which I'll be talking about. It's a 3.5 years old female patient. She's known to have a biliary atresia, and she presented to SKMC hospital with severe upper GI bleed. She was already in liver cirrhosis, and she had a failed Kasai procedure, which is a procedure done to treat the patient with biliary atresia. And also she has severe portal hypertension and gastric bleeding. It took Dr. Shbeeb around 4 hours to control the bleed. It was really massive from everywhere in the stomach. So at last, we managed to stabilize her, stop the bleed. And the only option was for this patient was TIPS, as you cannot do like a liver transplant immediately. So what's biliary atresia? Biliary atresia is really characterized by fibrous obliteration of the extrahepatic bile duct and cholestasis syndrome, and transition into the biliary cirrhosis in the end stage. It's not that common really, but it happened in 1 in 12 to 15,000 of newborns, and the etiology is really unknown. The hepatic fibrosis and biliary atresia prominently surrounding the portal vein, which make the portal vein small and also very hard to puncture. And this is what makes the TIPS procedure really very difficult in such patients. And some patients, they have a normal liver function, but portal hypertension happen in around 30% of those patients. And again, this is more information about the biliary atresia, and very important, as I mentioned, really that the portal vein becomes small, fibrotic wall, very difficult to puncture, but we have sharp needles. So what problem we face in this case? Family were really difficult, and they've changed their mind every 5 minutes about the procedure. Sometimes they accept, sometimes they refuse, but really we didn't have much time to wait for it, because we were scared of a second bleed which might kill the patient. And again, they have too many member of families who are doctors everywhere in the world, and again, every 10 minutes we have to speak to one of them and explain the procedure. At the end, really, they accepted the procedure, but one of the technical problems which we faced was the size of the tip set, because the available size was for adults. We didn't have a special size for children. And again, as I said, the risk of second fatal bleed, and also the experience of the PICU after such patient, and also the experience in TIPS in kids. And this was my first encounter to do a TIPS in a such age. So this is the picture from the patient. So I punctured the jugular vein easily, and then I went inside through the SVC right atrium and then entered the right hepatic vein. You can see the size of my sheath really is like the size of the right hepatic vein. And I did wedge hepatic venogram, so I inject contrast by wedging the catheter, and then the contrast reflex to opacify the portal vein in the retrograde manner. And then I could see the area which I have to target in the portal vein. So the anatomy was right, but the size of the baby was so small, so I have to be careful how much I have to push the needle, as I don't want it to go outside the liver. And then this is the first puncture. As you can see, already I have some capsular hematoma and also hematoma inside the liver. I started to panic, and my adrenaline level went up. Again, there's no way to stop here. So I did a second puncture, and I managed, luckily, to get into the portal vein. But again, the adrenaline level went up. And as you can see, there is subcapsular hematoma on the right here. But when I was inside the portal vein, so the tension eased off, and then I put a guide wire inside. And after that, contrast injection, I could see the gastric varices which were bleeding, and then I calibrated the tract and I inserted the special TIPS stent. It's called the Veto. Actually, it's partially covered, which stay inside the liver, and partially uncovered into the portal vein. And alhamdulillah, it was very smooth procedure. Didn't last like an hour and a half only. And then after that, patient went to the ICU for monitoring, especially for the ammonia and also for the risk of a bleed. And then next day, Dr. Shbeeb did upper GI endoscopy, and there was complete disappearance of the gastric varices, all decompressed. But unfortunately, it came to our surprise. Family decided to discharge the patient against clinical medical advice after 40 hours of the procedure. We spoke to them in length, but unfortunately, they were determined to take the child outside, and they took him outside. And luckily, we saw the child 6 and 12 months after, and she was doing very well. And actually, I saw her last year when she's 14 years old now, and she's still doing very well. And because they were supposed to go for a liver transplant, but they did not do it, and she lived kind of a normal life. So what's the literature say about the TIPS and biliary atresia? There are not so many papers. This is one of the largest papers, and it was written in 2002. They spoke about 9 children with biliary atresia and who had TIPS for gastric bleeding from varices. And they all agree that it was technically difficult because of the periportal fibrosis and small portal vein. And you can see the age of those children from the age of 2 to the age of 12 years old. And this is the experience, like over 9 years in one hospital. So there are not many of these complex procedures done. This is the second case, but different. This is Malik. He's a 15 years old Syrian boy. He came to us with podiatry due to polycythemia vera, and he came with massive ascites, malaise, weakness, or his liver and labs where they were deranged because of the thrombosis of the hepatic veins. So he came to us for a procedure, and as you can see from the CT scan, there's ascites, and also on the ultrasound scan, you can see thrombus inside the hepatic veins. And podiatry, what our strategy, we try to open the main hepatic veins by angioplasty or stent, but if we fail, you have to do with the tips. Again, this is you can see the labs, they all red. Bilirubin, albumin, all the range. And this is the procedure. Again, we entered from the jugular vein, and under X-ray guidance, we went to the SVC, right atrium, and to the hepatic vein. And you contrast injection, you can see the occlusion of the proximal origin of the right hepatic vein, but we managed to cross by a guide wire. And then after that, we angioplasted that occluded segment. Again, we went to the left hepatic vein, and also it was occluded. And again, we angioplasted this. And then we had to put a stent at the origin of the right hepatic vein to avoid re-occlusion, because it was recoiling after the angioplasty. And patient was discharged 2 days after. All the ascites disappeared, and he has been living like a normal life since that procedure, which is 10 years ago. He comes for a follow-up every year. We check on the stent in the portal vein patencies without any issues at all. This is another patient also. She's a 15-year-old female patient. She came with the upper GI bleeding. Again, she was diagnosed with podiatry 2 years ago. She had, unfortunately, in addition to the hepatic vein thrombosis, she had a portal vein thrombosis and also right IgV thrombosis. As she went to have a procedure abroad in Singapore with peritoneal right anterior jugular vein shunt, which thrombosed the jugular vein. And she was denied liver transplant because of the hepatic and portal vein thrombosis. And what made things worse, she had also recent pulmonary embolism, so she was on warfarin. As you can see, her liver is really very abnormal, large, dilated blood vessels everywhere. And so she came to us and she's bleeding, and the plan is to do TIPS as the portal vein and the hepatic veins were thrombosed. So the only hope for us is to go directly from the IVC anteriorly inside the liver to hit the portal vein, which is very risky procedure as you are puncturing kind of outside the hepatic parenchyma. And in case of massive bleed, patient will be really bleeding massively into the retroperitoneal space. And this is our needle. You can see it in the IVC, which is compressed and stenosed by the large coded loop. And we managed after 12 puncture to enter from the IVC into the dilated collaterals of the portal vein, as the main portal vein was thrombosed. And once we enter, we push a guide wire inside, and then we started to dilate gradually by a balloon. And once we reach a big vein, we inserted a stent. As you can see here, there's a big waist on the balloon here due to the stricture and the fibrosis. And we managed to open it. And as you can see, once the cyst is open, all these collaterals and gastric varices disappeared. And endoscopy next day showed disappearance of the gastric varices. Patient was discharged 4 days after. And she kind of lived a normal life after that. She comes every 2 years. We check here stent patencies. We had to do a couple of angioplasties because there is a chance of stent stenosis. And this case went to the media, as you can see here, as she seek medical treatment everywhere, and we only managed to treat her at Abu Dhabi. And this is a picture of the special stent which we use in TIPS. It's called Veto Stent. As I said, it's partially covered inside the hepatic parenchyma to stop the reflux of the bile into the stent lumen, which can cause stenosis, and also the uncovered part, we keep it inside the portal vein to avoid thrombosis. Complications, of course, bleeding is one of the major complications. Also, we could cause bowel perforation if the needle went outside the liver. There's a risk of infection and liver failure, especially patients with child debut P and C. And also, there is a risk of hepatic encephalopathy up to like 29%. And also, the stent could get stenosed and occluded, which is very easy to reopen by IR. Death rate, again, is not low, really. It's 1 to 22%, as the 30 days death rate in a child abuse C patient after TIPS is around 30%. And unfortunately, 75% of urgent TIPS patients who came with a bleed are already in child abuse C, so the risk of death is really high. We consent the family for this. And again, this is some images show you the some of the complications and the proximity actually of the hepatic and portal vein to the adjacent organs. As you can see, this patient here, he had a bleed inside the gallbladder and resulting in hemophilia. And again, this is puncture outside the liver parenchyma into the colon. So really we have to be very careful by using X-ray and ultrasound guidance when we puncture to avoid any complications. One of the common complications after TIPS is the hepatic encephalopathy, as we shunt the blood from the portal vein to bypass the liver directly into the main circulation, which carries a large amount of ammonia, which is the cause of the hepatic encephalopathy. And this is a really very, very, very big paper. It came from the UK. They talked about 197 patients who referred for TIPS over 10 years at different age. And actually, hepatic encephalopathy was present clinically in 35% of patients, but only 5% of those require TIPS occlusion or downsizing. Again, TIPS led to death and urgent transplant in 11% of those patients, but no death encountered during the procedure. Again, a word on the TIPS patency. So primary 1-year patency for TIPS is around, if it's uncovered stent, 25 to 66%. But for the Veto, which we use these days, it's more than 80%. And again, if stent stenosis are included, we can do a thrombectomy and angioplasty the occluded stents. How well does TIPS works? When we do it on those type of patients, 90% of patients who had TIPS to prevent bleeding from varices will have relief of their symptoms, as we demonstrated. And also, when we do TIPS to get rid of the recurrent ascites in liver disease patient, 60 to 80% of the patient, they get relief of the ascites. But also when TIPS performed for other liver conditions such as polycythemia, many patients will return to their normal liver function and normal activities. This is one of the abstracts and paper which we presented on TIPS in 3 children in Abu Dhabi in one of the conferences. So really the message, if you have a patient with a chronic liver disease, cirrhosis, like biliary atresia, and they are bleeding, and you did the endoscopy once, twice, and they keep bleeding, and the gastric varices, they keep reoccurring, I think this procedure TIPS is a good indication for them, which is, I think, a bridge to liver transplant. Thank you very much.
Dr. Jamal will not be available for questions, so we will move for the second speaker. Second speaker also is from United Arab Emirates, Dr. Wasim Fathallah. Dr. Wasim is a friend, and we worked together for 5 or 6 years at Sheikh Khalifa Medical City with the Cleveland Clinic. Wasim graduated from Damascus University, and then he went to the States for his pediatric residency at Henry Ford at Detroit, and had his pediatric board certification. Then he went to Texas Children's Hospital, where he did his fellowship in pediatric neurology and got his also certification in pediatric neurology and specialized in the child neurology in 2000. He is a pediatric neurologist at Mafraq Hospital, Saha at Abu Dhabi, Al-Mafraq actually, not Abu Dhabi. And he has interest in critical care neurology, in neurometabolic disorders, and end of life and Islamic bioethics. He has also had a master's degree in Islamic science. Dr. Wasim will be talking about pediatric neurology subject, and I'll leave this to see the title. Right. Let's start, please.
Assalamu alaikum. I just want to make sure you can see my screen and hear my voice.
Wasim, are you online?
Yes, can you hear me?
Okay. Assalamu alaikum. Nice to having us with you. Nice to having you with us. I'm really happy that you made it, and you will be kind of live presentation with us. Go ahead, please.
Wonderful. So in the interest of time, I think we'll move ahead. I chose a topic that would hopefully be of relevance to practitioners in the field, and advancements of a neuromuscular disease. And I really want to focus on the role of the pediatrician. With that, I will be reviewing some of the current advances in a select group of pediatric neuromuscular diseases, and then quickly identify some gaps in early diagnosis and timely management for those disorders, and leave you with an emphasis on the pediatrician's active engagement that is really key to successful care for these patients in this transforming time of translational therapeutics that are really changing the outcome of these patients. As a quick reminder, when we talk about neuromuscular disorders, we are talking about diseases that affect one or more levels of the motor unit. So starting with the anterior horn cell, and there is representative disorder would be anterior horn cells disease, spinal muscular atrophy in the genetic form.
Wasim,
and then you move from...
Can I interrupt you? Wasim,
Yes.
Can you put slideshow so it will be full screen? Is that possible?
I am on slideshow.
Okay, I'm sorry. Go ahead. Feel comfortable.
Yes, right.
Thank you.
And then moving down from the anterior horn cell, we go down to the nerves, and the representative diseases from terms of genetics include things like Charcot-Marie tooth and other hypomyelinating disorders, acquired like your Guillain-Barré syndrome. And then at the level of the neuromuscular plate, we have the congenital genetic myasthenic syndromes. Acquired disease include botulism. And then down to the level of the muscle fibers, Your genetic disorders include congenital myopathies, muscular dystrophies, and what have you. And I selected 3 specific disorders to go over very briefly, just to highlight the evolving therapeutic landscape. Mind you, all these 3 diseases a decade or so ago were just, rubber stamp, fatal, terminal diseases, nothing to do other than just supportive care until demise takes place. So starting off with the first disease that really had a transformation in its therapeutic landscape in the 2006, infantile onset Pompe disease. Now, Pompe disease is an autosomal recessive monogenic disorder that results in deficiency in acid alpha glucosidase in the lysosome, which impairs the metabolism of glycogen. So mind you, this is a type 2 glycogen storage disease, also known as acid maltase deficiency historically. Now, the accumulation of glycogen in the tissue results in disruption of the intracellular milieu and results in an impaired autophagy that progressively destroys muscle fibers and results in a progressive picture of muscle weakness, hypotonia, loss of respiratory function, bulbar dysphagia, and eventually death, either from respiratory failure or severe aspiration pneumonia complications. The Kaplan-Meier curve for survival of these patients in the pre-treatment era, as you can see, is a very rapidly progressive fatal disease. So by about 24 months of age, only 9 or 10% of the patients are still alive. And this is not only from the respiratory compromise, but as I will show you,
Dr. Wasim,
severe hypertension.
sorry for disrupting you, but your slides are not working with us. I think you need to show screen, to share screen.
I'm sorry, I thought...
Yeah, you should, on the icon down, share screen, then we can follow you. Yes, now we can.
Can you see my slides now?
Yes, make it full screen if you don't mind.
Can you see it now?
Yes, thank you.
Thank you. So just to recap, this is the Kaplan-Meier survival curve, and you see in Pompe disease by 2 years of age, 90% of the kids are dead. And this is in the pre-treatment era. Now, the landmark change happened with the pivotal study that looked at interventional treatment with enzyme replacement therapy with recombinant alpha glucosidase in these patients. And the primary outcome were event-free survival. And you can see that very early on, these patients separated the curve from the historical controls of untreated Pompe disease. And you have patients surviving in a much significant, statistically and clinically significant percentage with the treatment with recombinant alpha glucosidase. Now, mind you, there are some persistent morbidities and mortality in these patients, but this is a function of the severity of disease burden at onset, and it's also the function of other modifiers that relate to the patient's response to the enzyme with autoimmune antibodies. I don't have time to go into much detail with that. I can tell you that the therapeutic experience has evolved over the years, but this is 2006 was the turning point in the world of pediatric neuromuscular disease with a disease-specific treatment that actually changes outcomes and changes the lifespan expectation for these patients. However, where we continue to struggle and where the role of the primary care provider is in shortening the time from first symptom, as you can see in the green bars over here, to diagnosis to death. And you can see that between first symptoms and death, you can have an average of 4 months, which is a very short time and leaves us with a very narrow window of opportunity to try to address these patients. And I think until we have newborn screening done, we are only stuck with either selective newborn screening in families with a confirmed proband, or we need to become really very clinically astute in recognizing the phenotype of the infantile onset Pompe disease, which is a classical triad of profound hypertrophic cardiomyopathy, profound axial hypotonia, and weakness with bulbar dysfunction, and the very classical short PR interval, high QRS amplitude on EKG. This triad should prompt the physician to check for the enzyme deficiency of alpha glucosidase, confirm it with genetics, and start enzyme replacement therapy as soon as possible. The other phenotype, which is less of a time urgency, but it's important to recognize because it can be confused with other diseases, is the late onset Pompe disease, which, as you can see, this cartoon showing this child with a Gower sign as he or she tries to ascend from sitting position on the floor. And this is representative of a limb girdle pattern of weakness. So the late onset Pompe disease looks a lot like a limb girdle pattern of weakness. And the most common limb girdle pattern of weakness in pediatrics comes to mind Duchenne muscular dystrophy. So this slide here summarizes to you the most important two differential diagnoses with the infantile onset Pompe disease, which is SMA type 1, and with the late onset Pompe disease, which is Duchenne muscular dystrophy. Now, SMA type 1 has no cardiac involvement, no storage, normal CPK, but it also shares a rapidly progressive course, and it has a different treatment. So it's important to distinguish and recognize these two phenotypes from each other. In your clinic, when you see your preschooler with progressive pelvic girdle weakness and difficulty getting up from the floor and running, you think Duchenne, but you can also think of late onset Pompe disease when you don't have that dystrophinopathy confirmed on your genetics. All these three diseases can overlap in their presentation, but they are all confirmed by genetics, and they're all treatable by specific disease-modifying therapies. And with this, I'm going to switch to the second disease, which is spinal muscular atrophy. Now, this is an autosomal recessive disease that is pan-ethnic, pan-gender, males, females, no third gender, sorry. Calculated estimated carrier rate is 1 in 50, and the annual incidence is between 1 in 5 to 1 in 10,000. So in a country like the UAE, where I practice, with a 100,000 annual birth rate, we expect to see 10 to 20 new SMA cases every year. In the past, the 10 or 20 new cases, the vast majority of which will die in their first year or second year of life because of progressive disease. Today, this is changing because of the understanding of how these genes work and how we exploit the difference in their genetic buildup to the therapeutic benefit of the patients. So SMA, that's on chromosome 5, has a very unique genetic background. SMN1 gene is the gene that is homozygously deleted in diseased patients. In the normal state, the transcript of this gene should incorporate all exons, including exon 7, so you get a full-length protein that keeps you healthy. There's a backup gene called SMN2. In the healthy individual, it doesn't really matter how much SMN2 you have, but what we learned about SMN2 gene is that in the regular splicing, the transcript tends to exclude exon 7, so you end up with a very short RNA and a short protein that is not functional. However, in 10% of the times, this SMN2 gene transcript includes exon 7 and gives a full-length protein that looks a lot like the SMN1 gene protein. This variance in splicing has been exploited by some of the medications in order to tip the balance of splicing from incomplete to complete length protein, which will end up ameliorating the phenotype. Now, there are three main phenotypes for SMA type 1, which are the non-sitters, non-standards, SMA type 2, which are the sitters, non-standards, SMA type 3, which are the standards and walkers. However, all three types, once they start manifesting symptom, they will continue to progress into weakness and progressive loss of muscle power and milestones. So it's very important to recognize that these patients, no matter whether they are type 1 or 2 or 3, once they start manifesting symptoms, they will progress to manifest without treatment. Type 1, you will see that there's a rapid course with high fatality. Those who continue survival are doing so with chronic lifetime ventilation. Type 2, we can lose some of those to morbidity of cardiorespiratory compromise because of aspiration, pneumonias, and weakness. Type 3 typically have a good survival, but they will lose ambulation once they start getting weak. So the mechanisms of action of new therapeutics really focus on one of two things, either replacing the missing gene with gene therapy, which is now available, or modulation of the SMN2 encoded full-length protein levels by modifying splicing. And today, starting 2016, we not only have one treatment, we have 3 different treatments for a previously, not too long ago, universally fatal disease. And this is really transformational. And today, instead of talking to parents about you want to die at home or you want to die in the hospital, now we talk about what is the best treatment for you. Are you a good candidate for gene therapy? Let's go ahead and prepare you for that. Are you a good candidate for intrathecal nusinersen, which we can, and we have seen excellent response, and we have a global experience of more than 11,000 patients, or do you prefer a more convenient at-home oral form? And these medications, however, will not give us the results we want unless we have early recognition and early diagnosis. And this is a study that looked at time of symptoms to time of diagnosis between the different types of SMA. And you will realize that for the type 2 and 3, which are the milder phenotypes, there's a longer gap between onset of symptoms and confirmed diagnosis, because not all pediatricians and neurologists and physicians think about SMA beyond the infantile neonatal age group. And they want you to start thinking about SMA in patients who have limb girdle weakness, progressive funny gait. And the same study looked at the prevalence of first symptoms, comparing SMA type 1, type 2, type 3. And you will see that the type 2 and type 3 can be very confusing, with some difficulty with standing position, some hypotonia, some clumsy movements, running difficulties. So any child with otherwise unexplained gait difficulty, gross motor difficulties, test them for SMA so we can get them on treatment in time. Last disease, switching gears to Duchenne muscular dystrophy. This is a very common X-linked muscular dystrophy related to dystrophin gene deficiency. The incidence is 1 in 3,500 to 6,000 male birth, depending on what country you're looking at. And it's characterized since once the onset of progressive weakness by a rapid and relentless decline in movement, with the eventual loss of ambulation, acquired dilated cardiomyopathy, and then respiratory failure and compromise and death. There is a wide spectrum, however, of Duchenne muscular dystrophy, from the full-fledged DMD all the way to the mild polysymptomatic female heterozygous carrier. But I want to focus on the Duchenne phenotype because those are the patients who need a lot of care and support. And historically, in the 1960s, without treatment, these patients will die in their second decade of life. However, the second batch of cohorts comparing the survival of patients who get spine surgery and ventilator support, you can see an improvement in their Kaplan-Meier survival curve. Subsequent to that, the studies that showed the efficacy of steroids in dampening down the inflammatory response that happens in the muscles that are deficient in dystrophin due to the repeated wear and tear that kicks off an inflammatory cascade that results in muscle fibrosis and loss of muscle fiber. The introduction of steroids into the therapeutic landscape has improved the time to endpoint of loss of ambulation or dependence on ventilation or death. Today, we also have centers that are starting patients preemptively on ACE inhibitors as a cardiac protective drug. And you'll see that over the years, things have improved from the 60s, where we just did nothing, to the 70s and 90s, where we have active intervention with spine surgery and ventilation, to the later decades, where steroids have really prolonged the loss of standing, loss of ambulation, and loss of self-feeding in these patients. But the real change that has happened in the recent years is with the understanding of the genetic makeup of these mutations in more details. And today, we cannot accept a diagnosis of Duchenne muscular dystrophy based on clinical picture and a CPK. We have to have the genetics to understand the specific mutation and to look at the amenability of these mutations to the more advanced treatments that we have today. One finding in a subtype of Duchenne are patients who have a mutation that results in what we call a premature stop codon. So you have a patient who have a fully normal Duchenne dystrophin gene, but the transcript is not progressing because there's an early stop codon. And with a molecule like ataluren, you can read through this stop codon and then transcribe the full-length protein and salvage the phenotype. But this will only work if you have a residual motor function that is salvageable. And this study compared two cohorts of patients, one in the upper table that have a pre-treatment 6-minute walking distance of about 150 meters, and the second cohort had a pre-treatment baseline 6-minute walk test of more than 300 meters. So they were much better off. And although both cohorts separate the curve for treatment versus placebo, you will see that the therapeutic response is much more robust in patients who are better off before they start of treatment. So this is an important message to take home for early diagnosis, early initiation of read-through stop codon therapy. The more exciting development in the field today for Duchenne muscular dystrophy is with the development of exon skipping technology. This is a segment of the dystrophin gene, which is the largest gene in the body. These are 4 exons that, when transcribed, will fit nicely in frame. However, in the second line, you will see that if you have a deletion in exon 45, when it's trying to make that transcript, these exons 44 and 46 fall out of frame and cannot be transcribed. So you don't have a protein product. So you have the disease. With the development of exon skipping therapies, you're able to bypass the exon 44, which was adjacent to the deleted axon, and now you can re-institute the exons in frame so that the transcription can proceed. And although you have a shorter protein, it is still functional and still can ameliorate the phenotype. And this is a pie chart that shows you the different subtypes of exon amenable mutations in Duchenne dystrophy patients, and you see that almost 80% of the Duchenne muscular dystrophy patients have mutations that are amenable to skipping therapy. This is a summary of the current pipeline of products in clinical trials at different phases for such technology. But up in the first 3 columns, you're going to see 1, 2, 3 exon skipping therapies that are already in commercial trial, in commercial availability, and they are in our clinics, and we are able to present them to our patients. But the key for the success and outcomes in response to therapy lays here in the early recognition and early diagnosis. This was an old study in 2009 that showed that there is a 2.5-year gap between onset of symptoms and confirmed diagnosis. We can't afford 2.5 years of wasted time, because once these patients start progressing, you have a very rapid loss of ambulation, wheelchair dependence, and you have a suboptimal response to these therapies, no matter how specific they are and no matter how unique they are. And again, first symptom reported in one study at 2.5 years. It takes about a year to get to a healthcare professional. It takes about a year to get a simple, dirt cheap test like a CPK to confirm your diagnosis, and then you need about half a year to get your genetic confirmation. We can't afford this type of wasting of time in this time and age. So any child who has a motor milestone delay, that has an unusual gait, who has speech delay, you should immediately get a CPK. And if you have your CPK supportive of Duchenne muscular dystrophy, you refer to a genetic center that they can do the genetic confirmation and decide which therapy is more suitable for your patient. So this mnemonic is easy to remember: muscle, motor milestone delay, unusual gait, speech delay, CPK ASAP leads to early diagnosis in Duchenne muscular dystrophy. This is a table that shows you half a dozen or close to a dozen of neuromuscular diseases, genetic bases, that are currently under clinical trials, either in the preclinical, clinical, phase 1, phase 2, for either gene therapy, like for Pompe, gene therapy with microdystrophin for Duchenne, gene therapy for myotubular myopathies, enzyme replacement therapies for some other treatments. All these are evolving in the clinical trial landscape as we speak. So be ready to deal with neuromuscular diseases in the 21st century with more aggressive diagnostics, more rapid recognition of phenotypes, and shortened time to diagnosis, and then a true era of personalized genomic medicine that the pediatrician, the neurologist, the geneticist, and the support services need to work hand in hand to work on that. I will leave you with my last slide that highlights some of the new challenges we have with these treatments. These treatments, as transformational as they are changing the natural course of these diseases. Unfortunately, they are not yet curative. So what we're having is a transformation from fatal disease to chronic diseases with the emergence of some new phenotypes and challenges. Children who used to die early on with SMA and infantile onset Pompe disease, who we think of as cognitively normal, now they are living long enough to go to school, for example, in Pompe disease, and we are seeing some learning difficulties, speech delay that we didn't recognize before. SMA patients are living now long enough for the type 1 that they are developing complications when they start sitting. They are getting scoliosis that a type 1 SMA didn't live long enough to get in the past. So we need to be ready to deal with complications of this mortality to morbidity shift. And the best outcomes, I didn't have time to show you study on some of these treatments. The best outcomes in these patients are when they are started in the pre-symptomatic stage with the newborn screening or selective screening in high-risk families, where you are able to treat them before the onset of the disease progression, and these patients are having near normal development. So with that, I'm going to pause and welcome any questions, and apologize for some of the technical limitations I had with this presentation.
Very interesting and informative, as usual. As usual. I'm going to open the floor for questions. If you'd like to stay with us for the next 5 minutes, Wasim, I appreciate that.
Absolutely.
Okay, the floor is open for questions and answers. People on Zoom, welcome to join. Any questions?
Thank you very much, Dr. Wasim, for the excellent presentation. I want to take some from your experience about the cases in United Emirates and about the sensitivity of the CPK in detecting Duchenne muscular dystrophy. How much is sensitive and reliable? Because sometimes we do the CPK and it was negative in some patients. So I want to know if you have reliable data on the CPK sensitivity and the specificity for the Duchenne muscular dystrophy. Thank you very much.
Absolutely. Thank you for that question. CPK is very sensitive. There is normative data for pre-symptomatic patients, so that CPK is actually utilized to screen patients for Duchenne. You need to realize that the level of increase is dependent on what phase of disease you are in. So once your patients are symptomatic, the CPK typically is in the order of tens of thousands, and that's very sensitive. When the disease is very advanced and you have wasted all of your muscles and there's no more muscle to break down, your CPK will decline as a function of complete loss of muscle. While you're talking about labs, I want to highlight a very important thing. A lot of patients are lost in the diagnostic odyssey because they present with an incidental finding of high AST, ALT liver enzymes, and they end up in the wrong hands of Suhail, who rushes to put a needle in their liver to see why they have high transaminases, and the answer is really in the muscle. So always think when you have unexplained hypertransaminasemia, check the CPK for the possibility of the muscle source of these AST, ALT. So CPK is very sensitive, but it's not specific. So when you have high CPK compatible with Duchenne, you have to go for the genetic diagnosis because there are other differential diagnoses. The first part of your question, in terms of treatment, I missed the first part of your question, I'm sorry.
Thank you very much, Dr. Wasim. You answered it very, very perfectly. Thank you very much. I appreciate it.
Thank you.
Thank you, Dr. Fathallah. Nice listening to you. I wish I could see you. Thank you. Have a nice day.
Soon, inshallah. Thank you very much. Thank you. And I wish you all the success in your conference. Thank you.
Thank you again.
Today we have the honor to have a very well-known speaker. She is a guest in all the pediatric conference in Bahrain. We have Dr. Nariman Lotfi. She graduated from Turkey, and she has her master's degree from USA, and she has her residency program from Canada, so we can depend on an international speaker here. She has a lot of experience on the childhood nutrition, and she will give us a very important topic today about unfortunately a very rising problem among the children, which is the obesity in childhood and the causes and the risk factor. So the floor for you, Dr. Jalal.
Doctor, can we remove this?
Yes, thank you for this one.
So I can read it. Because I reduce the size thinking.
Unfortunately, yeah, it doesn't. From here,
Thank you. Good afternoon. I'll be talking about childhood obesity and causes and risks. Of course, most of the information that I will be talking about, it's generally known, but I try to add some new studies that have been done on the childhood obesity. Hopefully, we'll be able to wrap up all of it together. So the definition of childhood obesity is, according to the World Health Organization, for the age of birth to 5 years. Overweight is weight for height greater than 2 standard deviation above the standard median, and obesity is weight for height greater than 3 standard deviation above the standard median. When we come about obesity in children age 5 to 19, overweight is 1 standard deviation, and obesity is 2 standard deviation above the reference median. Prevalence of childhood obesity. According to World Health Organization of the Commission on Ending Childhood Obesity, the prevalence of infant and young child obesity is increasing in all countries, with the most rapid rates happening in low and middle income countries. This increase has been 30% higher than developed countries. If current trends continue, the number of overweight and obese infant and young children globally will increase from 42 million in 2015 2013 on the prevalence of overweight Bahraini preschool children was 9.8%. And by 2030, this study, it's about child overweight and obesity among Saudi children. Saudi Arabia, they have a big number of adolescent and child obesity, as we see, starting from the age 6 till 8, up to until the age of 11 and above. There is overweight and obesity in all age stages. This is a prevalence of childhood overweight and obesity percent in Arab Gulf states. As we see, Bahrain also, we have a big number of overweight and obesity in both female and males. This is just an old slide, but I want to show how obesity since 1980 up to 2010 dramatically increasing in all countries, developed countries, starting from Canada all the way to Australia. Another statistics shows that Japan, they used not to have such a prevalence of obesity, start having them until USA, which is well known. The highest number of childhood obesity is in USA. This is, in general, give us an idea about the obesity in all European countries. As we see, Cyprus is the highest in boys and girls, all the way to Romania for boys and Slovakia and the girls. So all European countries also, they have the same problem. So what is the causes of childhood obesity? Although the core of the obesity problem can be simply stated as an imbalance between energy intake and energy expenditure over a period of time, but the factors behind this are quite complex. Obesity is largely explained by a bio-socio-ecological framework whereby biological predisposition, socioeconomic, and environmental factors interact together to promote it. Obesity is therefore viewed as an ultimate outcome of a complex interaction of biology, environment, and behavior. If we try to count the causes of obesity, genetic factors comes first to the mind, and then we know early life influence, pre and postnatal, lifestyle, diet, physical activity, environmental factors, TV and fast food sector, family practice, psychological problems, drug-induced obesity, and hormonal disorders. When we come to genetics, there is two views. Studies suggest that overweight and obesity are conditions tend to concentrate within a family. According to studies, obesity risk is 2 to 8 times higher for a person with a family history comparing to a person with no family history of obesity, as well as energy intake and energy expenditure are also influenced by genetic factors. On the other side, studies also indicate that genetic characteristics haven't been changed since 1980, yet childhood obesity rates have tripled in these genetically stable populations. So when we're trying to get a conclusion, we would say there should be another factors that underlies genetics, today known as epigenetics factor. So what is epigenetic factors? Epigenetic means above or on top of genetics. It refers to external modification to DNA that turns gene on or off. These external modifications do not change the DNA sequence, but instead they affect how cells read genes, bringing genetic and environment in one way to turn genes on and off. Epigenetics are a chemical modifications around the gene, influencing gene expression. Epigenetic factors are reversible, such as sleeping pattern, diet, and physical activity. Systemic review from 32 twin studies in various countries worldwide indicates the importance of the interaction between genetic and obesogenic environmental factor on the development of the childhood obesity. We know there is some common genetic syndromes associated with childhood obesity, such as here in Bahrain also I see a lot, Prader-Willi syndrome, Lawrence-Moon-Cohen syndrome, Down syndrome, and Turner syndrome. The second cause, or second major cause of childhood obesity, comes early life influences. First of all, prenatal influence on childhood obesity, gestational weight gain. Children of women who gained an excess amount of weight had more than 4 times the risk of being overweight at age 3 years. Also, a pre-pregnancy bariatric surgery was associated with a 52% lower risk of children obesity. Gestational diabetes. Obesity rates among children whose mother had untreated gestational diabetes was higher compared with children whose mother did not have diabetes or received treatment for gestational diabetes. Maternal hypoglycemia leads to increased glucose transport across the placenta and in turn to increase both fat cell number and count. Maternal smoking. Although smoking during pregnancy tends to slow the rate of fetal growth, meta-analysis of 14 studies indicated maternal smoking during pregnancy caused associated with 50% higher risk of childhood obesity at age 3. Mode of delivery. Studies also indicate the impact of cesarean section on the risk of childhood obesity. Offspring delivered via vaginal birth had 31% lower risk of obesity compared with those born with cesarean delivery. Also, within family, individuals born by cesarean delivery had 64% higher risk of obesity than did their siblings born via vaginal delivery. Postnatal influences on childhood obesity, infant birth weight. There is reliable evidence from large cohort studies of a linear and positive association between birth weight and later life BMI, which may correlate with adiposity and lean mass. Infant weight gain. A meta-analysis found that accelerated weight gain during the first weeks or months of life is associated with a higher body mass index or obesity later in life. Breastfeeding. Multiple studies of breastfeeding versus bottle feeding indicate that breastfeeding was associated with 13 to 22% reduction in obesity in later life. Duration of breastfeeding. A meta-analysis of 17 studies of breastfeeding duration found that each additional month of breastfeeding was associated with 4% reduction risk of obesity later in life. Gut microbiota is increasingly documented to be involved in the dysmetabolism associated with childhood obesity. Several factors can alter the composition of the gut microbiota, like genetics, mode of delivery, method of infant feeding, but diet has also a big effect on that. Lifestyle and diet. Modification in diet in the last years. Increased carbohydrate intake. The decrease in healthy dietary fat got together with a compensatory increase in carbohydrate consumption, especially in the form of refined foods such as breads, cereals, and potatoes. Increased trans fat intake. Trans fat in maternal diet, especially during breastfeeding, associated with severe obesity and chronic disease later in life. That's why FDA has required that trans fat must be listed on food label commonly found in commercial bakery products and fast food. Increased high glycemic index foods consumption, such as white rice, potatoes, and which induces a sequence of hormonal events that stimulates hunger and cause overweight. Increased sugar-sweetened soft drinks and juice intake, which promote this promotes excessive energy intake and has high glycemic index effect. Increased energy density food intake, high in energy, small in bulk, affecting portion size, satiety, and total calorie intake, such as mayonnaise, ketchup, and French fries. One of the reasons in common that most of studies are talking about is increased fast food consumption as a best complex for the modification in diet contents. Fast foods are high in calories, carbohydrate and sugar, high in trans fats, fried style, high glycemic index, white bread, potatoes, high density like mayonnaise, and high in sugar like soft drinks. This fast food also causing deficiency in the critical micronutrients important for growth, such as vitamin D and iron. Environmental factors, TV and food sectors. Studies revealed that watching TV considered one of the most modifiable cause and represent an important risk factor for obesity in children through TV replace physical activity, increase energy intake. Children tend to consume excessive amount of energy dense food while watching TV. Television advertising of unhealthy food could adversely affect child's food choices throughout the day. Also, fast food companies and marketing strategies. Fast food companies generate enormous amount of money promoting fast food, linking fast food brand names with toys, games, movies, clothing, collectible, educational tools, and even baby bottles. Encouraging overeating, large meal can be purchased for little additional amount. Fresh fruits and vegetables are less available and comparatively more expensive. Physical activity and lifestyle. Sedentary behavior, watching television, playing computer games, lift to stairs, driven to school, to walking. Also low participation in sports and physical education. PE typically considered less important than academic discipline, and many schools eliminated physical activity as it is not important. Also, if it's available, it comes with large size exercise classes and lack of equipment. Limited after school activity, heavy homework schedule, absence of safe playground and parks. Family practice, especially working parents, prefer to keep their children at home rather than playing outside unattended to be able to complete their chores while keeping an eye on their children. Home environment, family practice, and adverse family experience. When we come to home environment, happy and more positive atmosphere reduce child's stress and comfort eating behavior. Family meals. We say a family meal a day may keep obesity away. Studies showed family meals decrease TV viewing, improve diet quality, provide psychological support and emotional connection among family members, and exposed to parental modeling of eating healthy. Also, family size studies showed 4 out of 5 parents of small families let their children make their own food choices. Also, besides that, they have always easier access to high-calorie snacks. When we come to family practice, change of concept from nourishment to lifestyle and a source of pleasure, particularly fast food, as it is more affordable and abundant. Parents' knowledge. has a lot to do with child's obesity, and I can see that in my practice. Parents' knowledge is very poor on healthy diet, food and snack choices, especially mothers' eating habit, physical activity, computer, video game use, and TV screen time. Families' unhealthy eating habits also, like eating out, eating fast food, high-calorie snacks between meals, skipping meals, and going for large portion other meals. Family practice also, like sedentary lifestyle, not participating in child's activities, engaging in sport less than 3 hours, 3 times a week, high screen time. Parents' weight, according to studies, 50% of obese children has one parent, and 80% of obese children has 2 parents obese. Families' indoor smoking habits and exposure of children to passive smoking. And families' high socioeconomic status. One make everything ready for the child, having housemaids, cars and stuff. Adverse family experience. Studies indicate that around 1/3 of overweight or obese children had 2 or more adverse family experience, such as divorce or separated parents, death of parents, living with someone who is mentally ill, suicidal, living with someone who had an alcoholic problem, witnessing domestic violence, being victim or witnessing neighborhood violence, suffering racial discrimination, or suffering due to very low family income. I don't know how is my time, how much time I left. 8, okay, so I have to speed up. Okay. Psychological factors. Children who suffer from neglect, depression, or other related problems are a significantly increased risk for obesity during childhood and later in life. Food is often used as a coping mechanism with bad emotions such as sadness, anxiety, stress, loneliness, and frustration. Stress and depression can influence a child's eating behavior. Children raised by their parents are more likely to be obese than ones who are raised by their parents. Association between maternal employment and childhood obesity is there. I'll try to go this fast. We know there's drugs-induced obesity. I'll try to put the most common ones like cortisol therapy, sulfonylureas, tricyclic antidepressant, MAOs inhibitors, oral contraceptives. If the child type 1 diabetes and on extra insulin, and some antidepressants and some mood stabilizers also. Also, there are some hormonal disorders that cause weight and obesity in children, like growth hormone deficiency, growth hormone resistance, hypothyroidism, leptin deficiency, glucocorticoid excess, polycystic ovarian syndrome, prolactin secreting tumor, and Ghrelin Leptin hormonal pathway dysfunction. This is a new study. I just like to share a bit more information about it. As we know, ghrelin and leptin are 2 hormones that play an important role in the regulation of food intake and body weight. Leptin decrease appetite, suppress food intake, and induce weight loss, while ghrelin increase appetite and induce weight gain. Both hormones are part of the peripheral nervous system and signal the brain, particularly hypothalamus, through different pathways. Dysfunction in the hypothalamic ghrelin-leptin hormonal pathway has been suggested to have a role in abnormal appetite and excessive food intake. Studies indicate that this dysfunction may be contributing into almost 10% of obesity in subjects. What is the risk factors of childhood obesity? The need to tackle childhood obesity lies not only in the avoidance of poor adult health. Childhood obesity leads to many acute health problems and much suffering during childhood as well. Today, it is well documented that obese children and particularly obese adolescents are likely to become obese when they're adult. Overweight adolescents who are followed by 50 years had increased age-specific morbidity and mortality relating to cardiovascular and other disease, and they were present even after losing weight during the adult period. That's very interesting. Also, obese children are more likely to develop a variety of health problems, such as type 2 diabetes, type 1 diabetes, hypertension, hyperlipidemia, evaluated liver enzymes, sleep apnea, and asthma, musculoskeletal disorders, early puberty, menstrual irregulation, and polycystic ovarian syndrome. Psychological problems. Childhood obesity can severely influence quality of life through its impact on social and psychological functioning, and has been linked to low self-esteem, depression, low educational accomplishment, and antisocial behaviors. It also comes of eating disorders such as anorexia or bulimia, increased risk of certain types of cancer, benign intracranial hypertension and stroke, skin infections. This is just a picture that I like. It summarizes all the risk factors that comes with the childhood and adolescent obesity, and short notes under them, talking about what is the best way and the shortest way to tackle them. In the treatment of obesity, I just want to mention one thing. No medication were available or approved till recent years for the treatment of obesity in children. But in April 2020, Food and Drug Administration has approved the indication of liraglutide for weight management among pediatric patients aged 2 to 12 and older. Age 12 and older, who are obese with body mass index above 30%. Liraglutide is a glucagon-like peptide 1 receptor agonist known as GLP-1 receptor agonist, also in the market known as Saxenda. Since then, vast number of studies indicate that the use of liraglutide combined with lifestyle therapy led to a significantly greater reduction of weight comparing to placebo plus lifestyle alone. Of course, metformin been used for a longer time, especially in treating polycystic ovarian syndrome. Antidepressant studies proved has not that big effect on obesity treatment. Surgical, we know the last 10 years, bariatric surgery had taken over, especially in adolescent obesity. Increasing evidence demonstrate that the effectiveness of bariatric surgery, especially in mature teenagers who have failed lifestyle modification. Nonetheless, the use of surgery requires experienced teams with resources for long-term follow-up. So this is just another small chart, how to end childhood obesity, promoting intake of healthy food, promote physical activity, pre-pregnancy and during post-pregnancy care, early childhood diet and physical activity, health, nutrition and physical activity, and also management. My last slide is to come to the conclusion. Prevention of childhood obesity must be multi-pronged and directed not only at the child or at the adolescent, but at their family, educational and social environment. Education to promote lifestyle modification for a healthy diet, physical activity, and supportive environment. This should be the primary goal to achieve effective, long-lasting result. Acknowledging the psychological burden that often accompanies obesity, children and adolescents should be evaluated for the presence of psychological problems if suspected. Clinicians need to prescribe and then support healthy eating habits. Healthcare teams should be also address family dynamics and their dieting and maybe contributing to a child's obesity. That's all, and thank you very much.
Thank you very much, Dr. Nermeen. I think your topic is very hot and need a lot of questions. And by chance, we have Dr. Fadila Al-Mahrous also, which has a lot of studies about epidemiology of different diseases in the childhood. So we can gain the experience for both of you. My question, did you feel that with the COVID-19 pandemic, there is an increase in the rate of obesity among the Bahraini children? And how we overcome this?
Definitely, I saw that. First of all, the lifestyle been modified big time. Children are online, and sleeping pattern been totally changed. Children stays on the line until 11, 12 o'clock, and then they sleep till late hours, stay awake all night. So this change in the sleeping pattern, as itself, it affects weight gain, plus it is changing their meal time. So dinner becomes 2 o'clock, 3 o'clock in the early morning. And I saw that. Even parents, they're complaining. But the problem is children are not willing. They're finding much more fun to stay this way. And families, I'm sorry to say, I can't see a good discipline to change that back to normal. So I'm always saying, try to start from now, because next year most probably we'll go out of online treatment. Yes, I did saw that.
Thank you very much.
Dr. Nariman, thank you very much. Beautiful. I have a question. I want to know what is the most effective way you follow to control obesity in children? What's your technique or style of management?
Usually I do a total analysis for the child's food intake, for like 24 hours energy intake, with the caregiver, if it's mother or the housemate. And then I bullet where is the mistakes, sleeping pattern, meal times, portion size, where is the child is eating his food, from outside, fast food orders, or homemade. And then before I start educating the child, because children, it's very hard to get them understand. So I start educating the parents, the caregiver, how to change from unhealthy lifestyle to healthy lifestyle. And when I do that, I don't do it all in one, because the child will reject it. We do 1, 2, 3, maximum 3 changes at one step. And I let the child go 2, 3 weeks, practice the new changes, and come back. And I find education is very effective, particularly if we do it in a proper way. Some parents are willing and they try, but some parents, they start very enthusiastic and then they give up.
That's good. I follow a different, more or less a similar system, but a bit different. I follow 4 major issues, putting in mind that I will not, the patient, I will not change the child's day-to-day way of living because I want him to lose weight. These 4 things are very simple. First, let's increase obesity is more calories in, less calories out, period. That is obesity in general. So let's cut back on in and let's increase on out. Increase exercise. That's 1. 2, I want to give him healthy food. And that's the major advice to the family. No more junk food, no more fat and oil and sugars. Let's go a bit healthy and gradually. It shouldn't be in a week or two, gradually. Number three is we cannot cut foods varieties from children. These are growing creatures. They have to get everything, vitamins, minerals, elements, you name it. So I advise the family, listen, if you put this much of food in the dish, put half of it.
Exactly.
All right? We cut back on calories. Now, the fourth thing, and this is a bit tricky, but I feel it's working. I work on the pectin hormone. Pectin hormone is the hormone that is secreted to tell you, I'm hungry, eat more, I'm still there. So what I ask the parent, and I tell them, it's like when you are sitting eating, and then you got a phone call. You went to answer the phone call, you came back, I lost my appetite. Bad news, good news, doesn't matter. They lost their appetite, but they're blaming the bad news. Not wonder if it contributes or not. What happened is that once you stop eating, the stomach is half full, let's say, the pectin settles down, it comes down. It doesn't tell you I'm hungry, eat more. So that's how I tackle it, in a way that put half of the amount of food you put before, let him drink a glass of water before he eats, fill his stomach. And this little half amount of food, and let him leave the table immediately. These three things will cut back on the pectin, leptin hormone.
Ghrelin.
It's more or less the same.
Yes. Yeah, it's the family. The problem starts from the parents or with the caregivers. Like the child doesn't eat salad. So I ask mother, do you eat salad? No, I don't like salad. He doesn't eat fruits. I ask parents.
Say, my son doesn't eat, right?
So how could the child learn to eat salad when the mother, or especially mother, has a big effect on child's behavior? If she doesn't eat salad, if she doesn't prepare it and make it available, the child will never learn how to eat or to consume salad. Same thing with the fruits, same thing with drinks. When mother doesn't drink only juice, child will not drink water.
Thank you very much.
You're very welcome.
Thank you, Dr. Nariman. Excellent presentation. It's my turn now.
I will introduce you from here, if you don't mind, Doctor. Our next speaker is Professor Mohammed Beltaji, walking in front of you. Here he is. Dr. Mohammed Beltaji is a senior consultant pediatrics at University Medical Center, the Arabian Gulf University here in Bahrain, and distinguished professor of pediatrics and pediatric cardiology at the Pediatric Department Faculty of Medicine in Tanta University in Egypt. He is very interested in research, and every few days I see that a paper published in his name. And these papers are published in high-ranked scientific journals, and he is peer reviewer and editor of several international medical journals. He contributed to publishing books and is a recognized speaker in many international and national conferences and organizations. Please, Dr. Mohammed, start.
Thank you very much, Dr. Sahil, for your presentation and actually for your invitation to be here among you. Today I will touch a problem which is on the rise, not only in Bahrain, but all over the world. So I will talk about the autism and from the pediatric point of view. So I will not talk from the psychiatric point of view. I will talk from the pediatric point of view. So I will talk about the comorbidities associated with autism. I have no conflict of interest, and this is actually the item that I will talk about it. Sorry. So what is autism? Autism came from the word autos, which means the self. So the child will be withdrawing on himself. And the child is like any other child. However, he is seeing the environment and the atmosphere from a different aspect. So he is a normal child. Autism is a change in the behavior in a normal child. So it is not a disease by itself. Okay, so what is autism? It is a developmental disorder that affects the children, usually diagnosed before the age of 3 years. However, sometimes it may have a delay in diagnosis. And it is a disease of a boy, so it affects the boys 5 times more than the girls. And it affects certain specific developmental area of the brain, so it affects the social interaction as well as the communication skill. So autism is a unique, totally intelligent, sometimes mysterious with different behavior. So he's a child with different behavior. So just a review about the common symptoms in autism. So he's have unusual play habit, very sticky to his toys. He is inability to make a communication with others, and he has abnormal or unexplained attacks of crying or laughing. Sometimes he may be hyperactive, sometimes on the other way, he may be passive. He sometimes may be oversensitive to the auditory stimuli, sometimes he may be unsensitive to that, with some strange attachment to object, very adherent to his stuff. So it is, if you take some from his stuff, he will go into a violent attack, crying, and aggression. He also have a very poor speech, and with lack of the speech, difficulty in dealing with change of the routine. This is very characteristic and unique feature of autism. As well as he has a lack of vision for the danger, and this is very important step because this makes him more liable for accident and for hurting himself. So we'll go now for the autism comorbidity. Before we go to the comorbidities with autism, what is the meaning of comorbidity? Comorbidity is the presence of another disease with another main disease. So it comes as a second line or second arrangement disease. Okay? It has a different and unique symptoms from the original one. However, sometimes there is some overlapping between the two conditions together. So comorbidity with autism is responsible for a lot of the complication and also responsible for the high mortality rate, which reach about 3 to 10 times than the normal, typically developed child. Here is the triad of the autism: the social deficit, the language impairment, and the repetitive behavior, which form the triad of autism. However, there is a lot of neurological and developmental disorder usually associated with autism, like epilepsy, like mood changes, anxiety disorder, obsessive compulsive disorder, and there is other systemic medical disorder that it is frequently present in autism. For example, gastrointestinal disorder, feeding problem, epilepsy, more liable for accident, toilet training problem, dysautonomia, hypothyroidism, autoimmune disorder, immune deficiency, and a lot of other problems. Then, why you are touching this important topic? Why we need to identify presence of comorbidities among the children who have autism? Sometimes this abnormal behavior that is present in the child is not related to autism, but it is caused by presence of this comorbidity. For example, if a child has an abdominal pain, he starts to attack his tummy, hurting his tummy. So you realize this behavior for the autism behavior. However, he wants to tell us, I have a problem in my tummy, I have an abdominal pain, I have a colic. It is also very, very difficult to let any normal child, not autistic child, to have a learning and to be effective in learning, and he has headache, for example, or he has abdominal pain. So it is very important to identify the presence of a problem in a child who have autism to ensure that he will be very effective and during learning procedures. At the same time, the child may lose the skill that he gained, or he may not able to retain the skill he acquired when he have a medical comorbidity. At the same time, presence of the comorbidity is responsible for the impairment of the intellectual function, the higher disability procedure, the more death rate, the more accident that the child will expose to. Comorbidity also, it could be a unique feature for the presence of other diseases, for example, epilepsy. Leaving these pathologies and comorbidities unidentified and untreated, this is unfair for a child who have the right to be equally treated and managed like any other child. At the same time, treatment of this comorbid condition, it will improve the cognitive function, it will improve the child's ability to acquire learning skills, to acquire developmental progression and improvement of his general condition if we properly treated this comorbid condition, as we will see in the next slide. Then, is it easy to identify the presence of comorbid condition among these children? Really, it is sometimes very difficult to identify this comorbidity. And it is very difficult to identify between the abnormal behavior related to autism and the behavior related to the presence of this comorbidity. There is a lot of problem to identify. One of the causes is that the child is unable to communicate with his parent or with the doctor to explain what he's feeling, what is hurting for him. Sometimes the symptom itself that is present in a child with autism is a little bit different from the symptom that it is present in typically normally developed child. At the same time, these symptoms may change over time. It is not stationary. It may take different forms. So sometimes it's very difficult to achieve recognizable symptoms and signs related to specific disease. At the same time, the symptoms also can change over time. So sometimes we relate the presence of this abnormal behavior for the autism. So we can rely, for example, banging his head, touching his head, hitting his head, as he has abnormal repetitive behavior. However, this could be the presence of otitis media or presence of headache. So he tried to relieve his pain by hitting his head, or at least to tell us there is something wrong, please help me. So there is a communication problem. So also the symptom itself may change among the normal general population and the changing over time. And also very important tool, and I think this is our role, to initiate a tool and an instrument to early detect and diagnose presence of this comorbidity among the children who have autism. So the first comorbidity is the genetic problem. Fragile X syndrome is a very important and little bit common among the children who have autism. Children with autism have a chance to have Fragile X syndrome in about 2 to 3% of them. However, the Fragile X syndrome children have about 1/4 to 1/30 of them have the chance to have autism. So if the child with autism will have Fragile X syndrome, the symptoms of autism and the symptoms of the Fragile X syndrome will be much more. For example, he will be more intellectually disabled. He will have repetitive, abnormal and marked repetitive behavior. He will have hyperarousal state and the other features of autism. As we know that the Fragile X syndrome, he has the triple A, which the large ear, the large face, the long face, and the macroorchidism, plus the other feature of a Fragile X syndrome. We'll go to the second genetic problem. Per se, Down syndrome is like any ratio in the normal population. It is the same like in the autism. As we know that the chance of having a child with Down syndrome is about 1 to 800. This is the same in autism. However, the children with Down syndrome have the chance to up to 40% of the children with Down syndrome to have some autistic feature, range from mild into typically autistic features. When the child with Down syndrome have autism, the complication of Down syndrome and the complication of autism will be more frequent than the child with autism alone. So they will have more chance to have congenital heart disease, more chance to have gastrointestinal obstruction, more chance to have epilepsy, more chance to have eye problem, and so on. Another very important comorbidities among the children who have autism is the presence of epilepsy. Why epilepsy has a unique comorbidity with the autism? Epilepsy per se is a spectrum exactly like the autism is a spectrum. So it has a different types, different forms, and so on. Epilepsy is a very common in the children with autism, and by the way, not necessarily to have a frank epileptic fits, but at least 60% of the children who have autism who have abnormal electrical activity. As we know that some of the normal people may have abnormal electrical activity. This is up to 6% of the population. This will be multiplied by 10 times in the children who have autism. So about 60% of the children with autism have abnormal EEG. And about 10 to about 30% of the children with autism will have epilepsy. At the same time, the epileptic children, the children with epilepsy, will have a chance up to 8% to have autism. So we can say that epilepsy is a comorbidity for autism, and at the same time, we can say that autism is a comorbidity for epilepsy. So can both of them work together as a comorbid for each other? And the severity of the epilepsy, it ranges from very mild, subtle, not distinguished feature like petit mal epilepsy, to a grand frank epileptic fits, and sometimes even epileptic encephalopathy can develop. Then, what is make the epilepsy unique for the autism? Because, you know, most of the underlying pathophysiology and mechanism for the epilepsy, they are the same for the autism. We can see that synopathy, excitopathy, channelopathies, problem in the glial cells, and the neuroinflammation, both of them are common for both epilepsy and autism. So when we're trying to treat one of them, we will treat the other and improve the other. So autism can proceed into epilepsy? Yes, it could be. Could epilepsy proceed to autism? Yes, it could be. And here we have an experimental production of autism in the young rats, that they produce an epileptic fit inside the very young rat, and they found that the rate of epilepsy of autism would be much higher among the rats that exposed to epileptic features. So they are connected? Yes, they are connected. Okay, what is the risk factor for epilepsy in autistic children, for children with autism? Autistic children is unaccepted the term. I use it by mistake, so I do apology for that. So what are the risk factors for epilepsy in autistic spectrum disorder? Being a female, unlike that the autism is a male disease, but having the epilepsy is more in the female than the male. It's number one. Number two, that the presence of intellectual disability. The higher the intellectual disability, the high rate for the epilepsy to be present, and the high rate for the autism to be present. About 50 children with autism and intellectual disability will have autism, will have epilepsy. At the same time, the presence of temporal lobe lesion, such as tuberous sclerosis, which is also a common genetic disorder in children with autism, they are more liable to have epilepsy, at the same time, more liable to have autism. So what we should do? First, we should recognize the presence of abnormal electrical activity or epilepsy. This is number one. Number two, we have to treat this abnormality very aggressively. Why we should treat the epilepsy in aggressive way? only every neurological spike, electrical spike wave, will delay the function of the brain cells by about 1 to 2 seconds. So you can imagine if the brain have a continuous electrical activity, then the function of the brain cells will be impaired for every spike 2 seconds. What about if this frequently occur? So do we need to treat the epilepsy? Do we treat the abnormal electrical activity in the children who have autism, who don't have frank epileptic fit? Or we may not treat? Unfortunately, there is no consensus about using or treating the epileptic fits or the abnormal electrical activity among these children. However, myself, I give that choice for the family. And I asked them to read it very well before we decide to start anti-epileptic treatment. So I give him that choice. Why I give that choice? Because there is no consensus to start or not to treat with the anti-epileptic medication for a child who have just abnormal electrical activity. Okay? At the same time, we have to educate the family and the caregiver about the presence of symptoms and signs of abnormal electrical activity and epileptic fit, which could be very subtle, that cannot be recognized. We have to treat and to educate the family to discover early such presence of symptom. If it is present, we have also to educate them what they need to do, what action they need to do. So there is video EEG is indicated, not the normal or the typical EEG. We should do video EEG for at least 12 hours for the children with autism who have the following data. If there is a strong intellectual disability, because about 50% of the children with autism who have intellectual disability will have epilepsy. At the same time, if there is a focal lesion like frontal lobe disease or presence of other genetic disorder like Angelman syndrome, Down syndrome, or a presence of tuberous sclerosis with the characteristic focal lesion in the front lobe, in the frontal lobe. Other neurological comorbidity among the children with autism is the presence of autonomic dysfunction, or what we call the dysautonomia. Dysautonomia, it appears in the form of increased epinephrine level among the children in relation to anxiety. At the same time, the rate of decline of the epinephrine level after anxiety will be very slow among the autistic children, so they need to have strong follow-up. So how can we recognize presence of dysautonomia among the children with autism? There is sign of increased sympathetic activity, and at the same time, there is signs of increased parasympathetic activity. For example, there will be alteration in the heart rate and its variability, change in the main arterial blood pressure and the systolic blood pressure, especially the nocturnal blood pressure. It is very, very important to check the blood pressure during the night time, because the first increase in the blood pressure will be nocturnal, then it will be diurnal, nocturnal and diurnal. There will be atypical pupillary light reflex, there will be atypical autonomic response to anxiety, there will be a lot of other conditions like raised level of norepinephrine and very slow decline in the level of the norepinephrine to the basic level. Other neurological disorder, which is a sleep disorder, it is also very common among the children with autism. Among this disorder, we'll have the insomnia, parasomnia, sleep-related breathing disorder like obstructive sleep apnea. Dr. Abdurrahman is here. He can also tell us about his experience. And presence also of circadian rhythm disorder, inverted sleeping during the daytime and waking during the nighttime, which give a hell for the family. Why it is important to recognize the manifestation of sleep disorder among the children with autism. The sleep disorder, if you don't sleep very well, the next day you will be able to gain experience, you will be able to gain knowledge from your teaching, from your educational. I think it is very important to make the child sleep well, to study well the next day. So sleeping disturbance is one of the most common problems that the family came to the doctor complaining with it. At the same time, the sleep disorder is not affecting only the child, it's also affecting the family. Imagine yourself that your child is awake during the night time and waking you. You don't sleep well, you will not go to the work in a proper way the next day, and so on. So the sleep community and the sleep expert, they recognize that children with autism as a very important target to start the treatment of this actual problem in the children with autism. So is there a link between the gastrointestinal disorder that it is common among the children with autism? Up to 80% of the children with autism have a gastrointestinal disorder and a sleep problem? Of course. If a child have abdominal pain, he will sleep well. If a child have, for example, constipation and he cannot go to the bathroom, he will sleep well. So the sleep disorder is very strongly related to the gastrointestinal disorder. Both of them are very frequent among the children with autism. About 1/4 of a sample of the children with autism have chronic gastrointestinal symptoms and sleep together. And 80% of the children have gastrointestinal disorder. So presence of chronic gastrointestinal disorder increase the risk of sleeping disorder among the children with autism. So there is also a link between the sleep disorder and the challenging behavior among the children with autism. If the child doesn't sleep well, he will have more stereotypy, he will have more repetitive behavior, he will have less educational ability, and there is a lot of problems that can enhance the presence of sleep disorder, like using medication, gastrointestinal disorder, presence of anxiety. All of them increase the risk of having sleep disorder in the children with autism. So another very important neurological comorbidity is the presence of the toy walking. As we have in the second lecture from our eminent speaker that he will talk about Duchenne syndrome, one of the very characteristic features is the toy walking for Duchenne syndrome. But this is also a common symptom and a sign among the children who have autism. Why they are walking on their toys? Why they have toy walking? Because they want to reduce the overstimulation. They want to reduce the contact of their feet with the ground to minimize the risk of overstimulation of such sensitivity, because they are very, very sensitive. However, it also could be related to presence of motor coordination among them, presence of tightness of the tendo-Achilles muscle, and because of the sensory processing disturbance that the children with autism frequently have. Most of them, I think all of them, have some form of sensory disturbance. So, toy walking also is present in other neurological conditions. The most important feature is the Duchenne muscular dystrophy. So, every child who presented with toy walking should have CBK level, as just mentioned about 1 hour ago. So what are the endocrine disorders that children with autism have? So there is an abnormality of the hypothalamic pituitary axis with excess formation of the adrenocorticotrophic hormone and consequently the corticosteroid, the cortisol level, which take long time to decrease after the stress. So this is a very important feature of the children with autism. Another important feature is presence of hypothyroidism. Hypothyroidism is very common even among the general population, especially in certain age group. However, this hypothyroidism rate is much higher in the autism, on the people who are suffering from autism compared with the general population. Therefore, every child who is diagnosed as having autism should have thyroid function test. Feeding problem. Children with autism are more liable to have different feeding problems. For example, they have aversive eating behavior. They dislike certain type of food. They don't like a lot of food, and they may have choking, gagging, expulsion of the food without a medical reason. On the other side, they will have more pica, and presence of more pica will expose them for more infection, gastrointestinal infection, and enterobiasis, which will be also one of the causes for abnormal behavior, and we may explain it as stereotypy or stereotypic behavior for the child. They also may have a sensory-based feeding problem, like being very selective and very restrictive for certain type of food. And they dislike the certain type of food, especially with the high texture. So they have a problem in swallowing. So we could help them with doing physiotherapy for the swallowing muscle. At the same time, because of the gastrointestinal disorder is frequent problem with the children with autism, so also the presence of a medically related feeding disorder is also very important factor for having such a disorder. Most of the children with autism have less than 20 type of food. They are linked for very few type of food. So this will expose them for more nutritional deficiencies. Yes, that the feeding problem will not affect their weight and height, will not be affected, but they will have more liable to have nutritional deficiency, certain vitamin deficiency, certain mineral deficiency, especially vitamin D, okay? And being very restrictive and very difficult in eating, they will expose them for child abuse. The child is refusing to eat, so please eat, and the family or the father or the mother or even the caregiver can hit the child and to enforce him to feed. So this will increase the risk of child abuse for the children who have autism. Effect of the biuron, there will be increase the anxiety level for them, and sometimes it could push them to abuse their children, and there is recorded cases. I think Dr. Fadila, she can tell us more about this. Gastrointestinal disorder, just I mentioned before that the rate of gastrointestinal disorder is very frequent. Up to 80% of the population will have gastrointestinal disorder. And there is a link between the causes of autism and the cause of gastrointestinal disorder. For example, the inflammation inside the gut is a factor for autism, at the same time for gastrointestinal disorder. The gut dysbiosis, the neuroinflammation, the dietary metabolite, all this is a common cause for both conditions, the autism and the gastrointestinal disorder. So many children, what's the time? How many minutes I have? Finished? Okay. So the most important problem is constipation, diarrhea, gastroesophageal reflux disease. Okay? So gastrointestinal disorder can be mixed with some abnormal behavior, for example, posturing, like going the head up, self-injury, abnormal crying, excessive, abnormal, more stereotypy, and so on. Celiac disease is very common in the children with autism. Also, the non-celiac gluten sensitivity also is very common among the children with autism. So sometimes it is very difficult for us to diagnose presence of gastrointestinal disorder because of the common symptoms that can be missed as abnormal behavior or other condition. So some medication, it also can give more problem and can aggravate the condition. However, what are the interventions that can be happen? Many children with autism will do very well on the gluten-free, soya-free, or dairy-free. However, this shouldn't be tested before, shouldn't be started before we test for the celiac disease and the gluten sensitivity, because it may give false result. Immune deficiency is very common. About 1/4 of the children with autism have immunodeficiency. So we can give intravenous gamma globulin in a rate of monthly. It will increase the cognitive function and improve the general well-being of the child. In conclusion, medical comorbidities are much common and prevalent in people with autism than in the general population. Such comorbidity is very difficult to be recognized. The failure to identify this comorbidity are related to the communication abnormality, the ambiguous symptomatology, the difficult symptoms, and the commonly held belief that this symptoms is related to the autism itself and not to the gastrointestinal disorder. leaving this disorder untreated, it's unfair, and it is one of the inequity of treating children with autism. Please, I'm a child with autism. I'm not an autistic child or an autism with a child. Thank you very much, appreciate, and I take only 1 minute more than time. Thank you.
Thank you very much, Dr. Mohammed. Any questions? Any questions from the Zoom team group?
So a gluten problem is very common, as we know, and you mentioned it's also a problem with autistic children. So if we're going to apply gluten-free, soy-free, and dairy-free diet on these children, for how long you advise? Is it going to be lifetime or for a certain time?
Okay, I think that's an excellent question, but this depends on which base you are making gluten-free or soy-free or dairy-free or dairy-free. Okay, what we usually do is we do what we call the footprint. The footprint is actually not accepted as a test, but we do it. We do it for epilepsy, we do it for autism, we do it for obesity, for migraine, for a lot of stuff. And myself, I saw a lot of benefits from following it. And I have many cases that get benefit from that. But unfortunately, it's not yet approved. But if you are doing gluten-free diet because of a celiac disease, this is lifelong. If it is due to gluten-free. But if it is, for example, you check the child and he doesn't have an evidence of celiac disease, and then you just try to improve the cognitive function by present, is it non-celiac disease gluten-free sensitivity? It's non-celiac means it is a sensitivity, gluten sensitivity, but not celiac disease. There is a complete difference between the two. So you can withhold for about 1 year, and then you try to give again after that. Exactly like the cow milk protein allergy, we will hold it for about 1 year, then we gradually introduce it. And a small amount when you are introducing the gluten, but not for the celiac disease. For the non-celiac gluten sensitivity, you introduce it in a very small amount and gradually increasing. It is exactly the same like doing sensitization. So how long we give depends on what is the diagnosis. So is it celiac disease or celiac or gluten allergy? Or you just try a diet and you see the outcome. Usually we try the diet. And if it is the child get improving, we will continue. If not improving, we'll revert back to the usual diet. Yes, Dr. Mohammed. Okay. So it depends on the cause and depends on the child input, the improvement. The improvement not necessarily in the abdominal sign, but it could be in the cognitive function. It could be in the abnormal brain electrical activity. For the non-celiac, it's 1 year, and then we try to give a small amount, and we'll see the response. For the celiac, long life.
Thank you very much, Dr. Mohammed. But we have to move to the next speaker, just to maintain the time. The next speaker.
It's okay, I will ask you later. Okay, no, thank you.
I'm sorry? Okay, short and brief, please.
Yeah, just short.
Thank you.
Once the child with autism is diagnosed, the family and the community start to isolate this child from the community. No, I mean, this is the practice. The child is autistic.
I mean, the practice in Memorial, Dr. Mohammed.
I mean the family, because they are not sharing the child with any playing area. Because I mean, how this will make the condition more worse?
Okay, let us just to take it bit by bit. First, after the initial diagnosis, yes, I do agree with you that the family will do what you mentioned. But later, they will accept the problem, and I will tell you that most of the mother and the family who have a children with autism, they are heroes. They are suffering, and they are searching, and they are doing every best you can imagine. Some of them families, they initiate the therapy themselves. Like, for example, high vitamin B12 therapy for the autism. One of the grandpa, he discovered it and he gave it to his children. So this situation, yes, at the beginning of the diagnosis, I do agree with you. But later, they accept it, they deal with the child, they do everything in their ability to let the child to live a normal life. And I found many kids, many children, they become nearly normal. So what you mentioned, yes, at the beginning, it's like a shock. And then they use for the shock. Then they start to adapt to it and they start to change their behavior. This is our role, to support them and to tell them this is not a stigma. This is just a test from the God. And you are able to tolerate this test, and you will do it, and you will succeed with it. Okay. Thank you.
Right, thank you very much. Our next speaker is Dr. Majdi Mansour. Dr. Majdi Mansour is a consultant pediatric cardiologist, certified since 2002. Dr. Majdi is a very, very good lecturer and speaker, and gets the message to the audience beautifully. Let's listen to him. He will discuss today pediatric ECG made easy, and I know that he will make it easy. Let's listen to how he does that. Thank you.
Good afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for inviting me to share with you some knowledge in this very nice meeting.
Dr. Majdi just contacted me from Saudi Arabia and Dammam, where he works at the King Fahd Medical City.
Of pediatric arrhythmia.
He is stuck with a pediatric ICU newborn baby with cardiac problem. This is why he sent me all this information. Go ahead.
Some touch on pacemaker rhythm and pulse management, mainly of bradycardias. This is Ensovin, the father of the ECG, with the first ECG machine. You can see now how big was this machine. And in this diagram, we show to you the relationship of ECG to electrical events in the heart, which can presented on the ECG paper on some waves. Ensovin actually called it A, B, C, D, E waves. But after discovering a wave after the E wave, he changed his mind and he takes the nomination from the middle of the alphabetics to be P wave, QRS complex, T wave, and U wave. The P wave represents sinus node depolarization and passing of the waves through the right and the left atrium. Then the wave will stay a little bit in the AV node. Then it will move and penetrate the tricuspid valve to the bundle of Hess. Then it will divide to right and left bundle branches, then to Purkinje fibers. This is the pathway of the electrical impulse from the SA node. It passes through two ways, one through the right atrium first, then through the left atrium, then connect together or collected together to the AV node, then bundle of Hess, then right bundle, left bundle, Purkinje fibers. The speed of conduction in the SA node is very slow, 0.05 meter per second, because SA node is poor in gap junction. Gap junction is windows between the cells with high permeability to the anions and to the trace elements and to the minerals, to allow easily transmission of the electrical impulse. While the speed of the electrical impulse is 1 meter per second in the atria, bundle of Hess, and ventricular muscles. But in the bundle branches and Purkinje fibers, to allow very rapid arrival of the impulse to every single muscle in the ventricle, the speed is 4 meters per second, because this bundle branches and the Purkinje fibers are very rich in gap junction. How the machine will translate the electrical impulse to a wave on the ECG. let me tell you that there is standard ECG paper like this. I will not go on the small details, but we agreed that the electrical impulse which is going towards the electrode will be reflected in a positive deflection, and the electrical impulse which is passing away from the electrode will be deflected in a negative deflection. So the impulse, as I told you, starts from SA node, then moves through three main channels in the right atrium, then through the left atrium, and passing through the right atrium will give us the first half of the P wave. Passing through the left atrium will give us the second half of the P wave. Then there will be a delay, like a station of trains. When trains delay in the PR which is the PR interval, this allows the blood to be collected in the atrium. Then the impulse will pass through the bundle of Hess to right bundle branch and the left bundle branch, because the direction of electricity in the ventricles are different from the atrium, some going down, some going up, some going in the septum. This gives us the different direction of what we call QRS complex, which represent ventricular depolarization or ventricular contraction. When the ventricle relax in what we call repolarization, this gives us the T wave, and the repolarization of the septum sometimes recorded and they give us a small wave, looks like the T wave, which we call it U wave. In the repolarization of the ventricle, there is two types of refractory period. In the first half of the repolarization, we can call it absolute refractory period. In this absolute refractory period, any cell that generates impulse will not be conducted because the ventricle is just contracting right now. We need some time. It is like when you eat some food and you are full and somebody will say, do you want to share with me a sandwich? You will say to him, no, I am full. But after 2 or 3 hours, you can share the sandwich. In the second half, there is what we call relative refractory period. Imagine with me this, we will talk about it later on. We can call this from the beginning of the Q wave till the end of the T wave, the QT interval. Whenever you have long QT interval, like long QT syndromes and other drugs, etc., you will have relatively long refractory period and long relative refractory period. And in this relative refractory period, ventricular stimulation and contraction can happen. And this what we call VTAC or ventricular premature beats. Just for your knowledge, the LV is almost 3 times the right ventricle, and the impulse goes on the ventricular septum from left to right. That's why the Q wave is down on the ECG. How the ECG will record every wave? The electrodes looks to the heart either from vertical, like the V1, V2, V3, or we have the leads of the heart, lead 1, lead 2, lead 3. So if you collect both of them together, you will find that the direction of the impulse from the sinoatrial node to the the node before the tricuspid valve is like that, 0 to 90 degree. So the normal B wave will be upright in leads 1 and AVF and inverted in AVR. If you don't know the normal, you will diagnose abnormality without any abnormality. Like many refer that the P wave is inverted in AVR, that's normal, and that this is a normal ECG. If you will find P wave upright in AVR and the leads are connected rightly, this is dextrocardia. The Q wave is the depolarization of the septum, and this is the direction of the electricity. As I told you before, it goes from the left to right, so it represented by a negative deflection, which is the Q wave. The axis of this wave is 180 to 270 degree. The R wave is the impulse that goes to the apex. So it is positive because it is towards the electrode, lead 1 and the AVF. Lead 1 is to the left of the patient and the AVF to the ground. So it will be positive again in lead 1 and the AVF, and the axis will be 0 to 9. Opposite to that, the S wave, which is waves going to the base of the heart, and it is against the R wave. T wave is quite similar to the P wave, and it is both upright deflection in lead 1 and AVF. So how to read pediatric ECG? Is pediatric ECG is a small ECG of adult? No. There is a big difference between pediatric ECG and adult ECG. That's why I like to use this classification. You can start by very simple things: introduction, name of the patient, for legality, age of the patient, because the ECG of 1 day age is not like the ECG of 1 year, 10 years, 20 years, and calibration, because sometimes we use half calibration, double calibration. In general assessment, everybody of you knows that we have to calculate the rate and to know the rhythm of the heart and the axis of the heart. But you will be left with special waves, intervals, and segments. The special waves are 5. So if we calculate this all, 3, 3, 6, 5, 11, intervals, we have 2 intervals. So 13 and segment, 1 segment. So